All right, good morning, everyone. Thanks for joining us this morning. This is a special edition of the CME offering. The Patient Safety Coalition of District 7, which is this side of the region of state of Indiana, is actually sponsoring this event this morning. And we have some sponsoring funding actually through Indiana Hospital Association because Sepsis Awareness Month is actually September. So we wanted to make sure we were kicking the month off good with a nice, good lecture. Online, we have about 6 or 7 other locations that are going to be listening and watching the same thing that's going to actually go on here in the room. So I'm not going to spend much more time than that. I am going to introduce Dr. Jaffrey and Leslie Probst, who will be actually our guest speakers for today talking about sepsis. So Leslie, I think you're kicking us off. Thank you.
Thank you for that introduction. As Rhonda said, my name is Leslie Probst. I'm one of the clinical pharmacists here at Union Hospital, and I work in our emergency department. I've been here for just over 7.5 years, and the first 4 years I was in our ICU, and then about 3 years ago moved down to our emergency department. And I've also been the chairperson of our sepsis committee for about the last 3.5 years. So today, Dr. Jaffrey and I are going to talk about the detection, resuscitation, and also the prevention of sepsis and septic shock. We're going to go through some definitions. We're going to talk about the early warning signs and screenings that we can do to identify these patients. We're also going to look at the resuscitation goals for 3 and 6 hours after the recognition of sepsis, and also describe some prevention strategies that we can use to prevent patients from progressing to sepsis. To wrap it up, I'm going to touch on the CMS quality measure for sepsis as well, because that's still fairly new. And I'm also going to just share a little bit about our experience and what we've done to really target sepsis resuscitation to improve our outcomes for our patients. To start, we'll just touch on a little bit of background. So sepsis is the body's overwhelming and potentially life-threatening response to an infection. We're going to look a little bit more into detail about the definitions of sepsis, but it is important to note that sepsis is not an infection itself, but the body's overwhelming response to an infection. Sepsis does have a high mortality. In Indiana, it's been associated with nearly 3,500 deaths and over 250,000 deaths in the US as well. That translates into a fairly high cost burden for our health systems as well. In Indiana, it was found that the charges for an inpatient sepsis stay was just over $40,000, and sepsis was the most frequent inpatient diagnosis in Indiana, aside from deliveries. So you can see that that really translates into a high cost burden. One of the most important things to note about sepsis is that it, just like acute myocardial infarction, just like acute ischemic stroke, sepsis is a time-sensitive disease state. Because of that time-sensitive nature, it requires early identification and prompt treatment to reduce the mortality associated with it. And because of that time-sensitive nature, we need to identify it early. And so we're going to first start and talk about the detection of sepsis. And we're going to do that through discussion of a patient case. So our patient today is LB. She's an 87-year-old female residing in a local extended care facility following an ischemic stroke. The staff has noticed an increase in confusion from her baseline and decreased use of the bathroom in the last 24 hours. However, when the patient has used the restroom, she's been complaining of flank pain as well as pain while voiding. Her past medical history is listed there for you. And the staff did some vital signs. I'm sorry for the spacing on this slide, but they found a temperature of 99.7, heart rate of 95, respiratory rate of 28, and a blood pressure of 88/50. So that leads us to our question of, does LB have sepsis? Well, before we can determine if she has sepsis, we have to know what sepsis is. And there are new definitions for sepsis, and they were developed by the Society of Critical Care Medicine as well as the European Society of Intensive Care Medicine, and they were published in February of this year, 2016. Sepsis, in these definitions, they defined as a life-threatening organ dysfunction caused by a dysregulated host response to an infection. So there are 2 main components to that definition. You can see organ dysfunction is needed to say the patient has sepsis, and that organ dysfunction has to be caused by a dysregulated host response. So this definition emphasizes the potential increase in mortality associated with sepsis compared to patients who just have a straightforward infection. So not every patient with an infection has sepsis, and we can see that in this visual here, that only when there's an inflammatory response that's overlapping with infection do we have sepsis. If you are familiar with the previous set of sepsis definitions, you'll note that there is something different than in these current definitions, and that is the lack of the SIRS criteria, or the systemic inflammatory response syndrome. Previous definitions of sepsis had 2 out of the 4 SIRS criteria had to be present, plus a source of infection. And so the SIRS criteria are listed there for you. The panel that developed the new definitions felt that while these criteria can still be useful in the general diagnosis of infection, it didn't necessarily translate into that dysregulated response, and in many cases reflected an appropriate response to infection. So because of that, they did not include the SIRS criteria this time, because they were really trying to focus and pull out those patients that are a higher risk mortality, and those are those patients that have that dysregulated response to infection. The other component of our definition besides the dysregulated response is organ dysfunctions. And in these new definitions, organ dysfunction can be identified as an acute change in a total SOFA score of greater than or equal to 2 points. So a SOFA score greater than or equal to 2 reflected an overall mortality risk increase of 10%. And that's why that value was chosen as a kind of a marker, because that's going to separate these patients and they're going to be at a higher risk for mortality. Change in SOFA score has been evaluated specifically in septic patients, and it was shown that there was a positive relationship, meaning that an increase in SOFA score did translate into an increased risk for in-hospital mortality in patients with sepsis. So the SOFA score is widely used in critical care, and it gives a score or a rating depending on the severity of organ dysfunctions. And this is an example of the SOFA score. So you can see that based on the patient's values, they get a score of either 0 to 4. Those are all added up, and then that is the patient's total SOFA score. And you can see that it includes respiration, coagulation, liver, cardiovascular, central nervous system, as well as the renal system. So those are the organ systems that are evaluated in a SOFA score. And we will calculate a SOFA score here in just a few minutes. Sepsis, if left untreated, will progress to septic shock. And in our new definition, septic shock is defined as a subset of patients with sepsis in which the underlying circulatory and cellular metabolic abnormalities are profound enough to substantially increase mortality. So what does that mean? Objectively, septic shock is defined as patients with persisting hypotension that require vasopressors to maintain MAP greater than 65 and a serum lactate level of greater than 18 milligrams per deciliter or 2 millimoles per liter. Previous septic shock definitions was an either or. So septic shock in the previous definitions was either persisting hypotension or an elevated lactate. What they found that when they went through the database of patients, they found that really when both of those are present together, it place that patient at a higher risk of mortality than either one alone. And that is why with these definitions, both persisting hypotension requiring vasopressors and a serum lactate elevation is required to say the patient has septic shock. So let's go back to our patient and apply these definitions if we can. So looking at the information that we have, do we think LV has sepsis at this point? Well, we can't calculate a SOFA score at this point because we don't have any lab values. So in order to say the patient has sepsis, we're looking for an increase in our SOFA score of at least 2. And right now we can't do that. So with these new definitions, there's also an introduction of a new screening process, which they call the quick SOFA or Q-SOFA. So the quick SOFA has 3 different components. We're looking for altered mental status, respiratory rate greater than 22, and a systolic blood pressure less than or equal to 100. What they found was that the presence of any 2 out of the 3 of these components was shown to identify patients with a suspected infection that were more likely to have poor outcomes. So this was an easy way of evaluating patients to look and see, are they at a higher risk for poor outcomes? The nice thing about the quick SOFA is that it does not require laboratory monitoring. You can do it really quickly at the bedside to assess the patient and say, Do we need to escalate care? Do we need to do further investigation? Because the quick SOFA is not intended to identify sepsis patients specifically, but it is intended to be used to prompt further investigation or an escalation in therapy. So let's look at the quick SOFA with our patient. We can see that she presented with increased confusion from baseline, so she has altered mental status. She has a respiratory rate of greater than 22 at 28 breaths per minute, and she has a systolic blood pressure less than 100 at 88. So with the quick SOFA, we would say that she has 3 out of the 3 components present, plus a source of likely infection because she's complaining of flank pain as well as pain while voiding, which could be a urinary tract infection. So this patient would be a positive screen for SOFA, or for sepsis, because she has a suspected infection plus 3 out of the 3 quick SOFA criteria. So this patient was transferred to our local emergency department for further investigation. And in her initial presentation, we have the following values. We can see her temperature in the emergency room is 100.4 degrees Fahrenheit. Her blood pressure, 86/45, which translates to an MAP of 58. Her white blood cell count is 15,000. Serum creatinine was 2. Her initial lactate level is 27 milligrams per deciliter, or 3 millimoles per liter. She has a GCS of 13, and urine was sent for urinalysis, and we can see that it is showing signs of a urinary tract infection. So now that we have this initial information, we can go back and look at that SOFA score to determine whether or not LB has sepsis. So going back and looking at our different criteria, we can see that she has an MAP less than 70. So that is 1. So we can see that assigns a score of 1 so far. She has a GCS of 13. She also has a serum creatinine of 2, which is not her baseline. So added up together, she has a total SOFA score of 4. So a setting of urinary tract infection plus an acute change in SOFA of 4, we can see that she does have sepsis. So just as a quick review of that screening process, we have a suspected infection. She had a quick SOFA of 3 out of the 3 criteria met. Once we had those initial labs and that initial evaluation, we can see that her acute change in SOFA score was 4. So she does have sepsis. Now that we know our patient has sepsis, it is time to talk about the management and resuscitation of these patients. And for that, I'll turn it over to Dr. Jeffrey.
Good morning. Thank you, Leslie. Leslie has been a champion for sepsis in this hospital for the last 7 years. You have done really great jobs over here. So I will proceed with the management and resuscitation of the sepsis. In every disease, when we talk about the management, we always go back about 3 components that's very important in patient care: history, physical examination, and labs. And with these 3 things, we gather information, as you heard Leslie about diagnosing sepsis. History is very important. 2 sentences will tell you what's going on with the patient. The intake nurse tells you the patient was fine, and also the patient was confused with fever and chills. Then you have a diagnosis. You say this patient may have meningitis. Patient with burning with urinations, with left flank pains, with hypotension. That's your diagnosis. And history is start from either the patients, the family, paramedics, extended healthcare nurses, and also from the physicians. And it's very important to know the history, exactly what's going on, so that you can direct your treatment according to presentations. I have seen several patients intubated, sedated, and at the time there was no history taken by it because the family was not present. Paramedics intubated the patient. Patient is in ICU. Luckily, the family was beside the bed, and I say, "Tell me what happens." And she said she was fine. She went to bed, and then she wake up, and she couldn't able to breathe. And with all the history and the gather and data, we came to know that the blood culture is negative, the blood culture is positive, as chest X-ray negative, urine negative. So patient is that she has meningitis, and we did LP, and she has meningitis. So history is very important in taking care of sepsis to identify what really exactly going on. Physical examination is very important, from the extended healthcare facility to paramedics and nurses. You have to pay more attention about their mental status. If this patient is confused, patient has decreased ulcers, polycatheters. These are all the information that are very important to check. Labs, it's very important because it will help us to diagnose patients. It will help initially to make the case of diagnosis, and also very helpful in taking the patients after patients move to ICU. Every disease has pathogenesis that we have to understand to treat the patients. And if you do not know the pathogenesis, it's very hard to treat the disease. And infective organisms activate the immune system, and it's entered in the body, produce cytokines which interact with your cells, which cause vasodilation. That's cause hypertension. The patient's vessels dilate so much that patient drop blood pressures that lead to hypertension, lead to hypoxia, lead to blood supply in the brain, kidneys, and livers, and cause symptoms and signs and symptoms of sepsis. Apoptosis is endothelial cells that is called dead cells, which activate the coagulation response, causing microthrombolysis, thrombosis, leading to end organ failure, and that is where we see the end organ damage with the hypoxia, along with the activation of the coagulation system. So early recognition is very important in the management of sepsis. You do not have to wait. You say patients is this patient has 87-year-old with left lung pain, as we have our case, and patient with fever, hypertension, and you start, you recognize and you activate your team to take care of the patients. It's a team measure. It's not one person can fix this thing. It's really sick people. This is the patients that are need to be hospitalized. Prompt and excessive focus on restoring and maintaining tissue perfusion is really critical for these kind of patients. Teamwork. As soon as patients start from paramedics, from a nurse who's taking care of the patient in extended care facilities, providing good history physical to the paramedics lead to intake nurse conveys to the physicians, and that's how the change works. Patients will be worked up pretty fast, chest x-rays, labs drawn pretty fast, and have started every. So resuscitations, what are the guidelines? The guidelines usually is being provided by Surviving Sepsis Campaign. It's been combined with the United States and the Europeans, and they give us the guidelines in the shape of bundles. What you do in 3 hours and what you do in 6 hours, to give us the guidance so that we will be in the right direction. If you do not have direction and you do not have guidelines, sometimes people wander around, and the cares usually get affected. So 3 hour bundle, which is as soon as patients arrive, you took history physicals, you did good examinations, and you start treating patients as soon as possible. You do your lab work, you do all the blood work that you want, you do the blood cultures, and you do antibiotics, and you administer fluids as soon as possible. So as you did the initial management, you do the blood work, which is according to the patient, CBC, CMP, UA blood cultures ×2. Make sure that you have a portacat or any central line, or permacat, you will do 1 blood cultures from those lines. You do a urine culture. The patient has come with peritoneal catheter. You do cell studies and peritoneal catheter. These are very crucial elements to help the patients in the next 40 to 72 hours. Labs are very helpful in diagnosing patients. In many cases, whenever patients come with peritonitis, sign of sepsis, and I go to the sticks, and we do not have any steady cell counts, and then the care gets delayed. Lactate level is being addressed in In the 3 bundle, is simply provided patients intracellular cellular level hypoxia. It's a test that I really don't like, but you know, I gotta do it. Sometimes you gotta do whatever is told to do. I get more patients. I have several cases that where the lactate level is high, but patient was not septic. There are a number of cases that patient have that cause high lactate level. But again, you gotta have a gut feeling. You gotta have to just say, hey, patient is confused, hypertension, tachycardia, fever, or hypothermia. That's your sepsis. You do not have to wait for the lactate to come and say, hey, this is your sepsis. This is not that you have to wait. I get a call from floor. A patient has fever, hypertension, tachycardia. Do you want to do lactate? I say, why do we need a lactate? Just treat it. Just go for antibiotics. Just means yes, you do it to make confirm, and then you follow up with lactate that it we'll talk about in 6 minutes. But when you order, the nurse call, take 15 minutes for physician to respond. 15 patients, 15 minutes. The labs comes. Then you call the nurse. You lose at least 40 minutes, where it's critical in this kind of patient that you need to start treating this patient. Antibiotics. Make sure that you've done your blood cultures, all the workup before starting the antibiotics. It's having said the 3-hour bundle, but we can do much more better than 3 hours. People can get antibiotic within 1.5 hours. You require 40 minutes for your labs. You make your decisions. You know what is the diagnosis by history, physical, and labs. Your antibiotic should be administered within 2 hours. It's very crucial. Your antibiotic should be appropriately be aligned with your diagnosis. If a patient with suspected meningitis, you start high doses of antibiotics, and communication is very important with pharmacies and so forth. So to increase dose the antibiotics appropriately. Fluids is the main initial component. Hypertension is you have to treat aggressively. You gotta, if patient is hypotensive and patient is septic, you know, my goal is that you have to stand in front of the patient and check the patient every 15 minutes. Fluids. Not too long ago when I was a resident, there was an argument between an attending and a fellow, and the attending wants to start the vasopressors, and the fellow says, give me another 40 minutes. Let me see if I will bring the blood pressure up with fluids. And then she did. She improved the blood pressure with just the fluid, not the pressure. So the fluid challenges are the most important, crucial elements. If a patient's in the nursing home who has signs and symptoms of sepsis, start the peripheral line, keep the fluid rather than waiting for 15 minutes for the paramedics to come around. Start the fluids, which is very essential. You have to fill up the tank, because whenever you're vasodilating, you're dropping the blood pressure. You need to fill up the intravascular volume before you put the pressors, because if there's nothing intravascular, then what are you compressing? What you are pressing? So that is a logic that you do 30 mL per kg bolus. I usually go by liters. Usually liter by liter. It's just a game. You just give a fluid, you watch your blood pressure, what pulse, see how the patient is doing. If not, keep doing boluses unless you have other contraindications. You have patient has congestive heart failure, insufficiency, and so forth, and that's where it plays your examination. So the patient's case, she has sepsis. We did the blood cultures, UA, all of the labs. We started antibiotics, and we gave the bolus within an hour. The blood pressure is 80/60. She has persistent hypertension. hypertension and lactate, patient has septic shock. 6-hour bundle. 6-hour bundle usually implies in critical care, in ICU, and the 3-hour bundle really make the diagnosis and do the early resuscitation, which predict the 6 hours bundle. In 6 hours, you repeat the lactate, see how's the lactate level doing in respect of perfusion. You discharge the vasopressors if your blood pressure is not coming up with the fluids, reassess the volume status, and tissue perforation. I will go. So there are 2 ways to manage these kind of patients in ICU. One is early goal direct therapy, which means that you have central line, you have CVP measurements, you have central venous oxygen saturations, and you have bedside cardiovascular sounds. These are called early direct goal therapy for providing fluid resuscitation. Other is traditional. We do not have central line, you do not have other apparatus, so you depend upon your physical examination, you depend upon vitals, you depend upon your cardiovascular examinations. A patient has pulmonary edema, a patient is renal output, peripheral pulse, you need to have A-lines, capillary refills, and skin examinations. And that is mainly is the goal. Traditional is the way because of our community. They are small hospital, and most of the hospitals is due to traditional rather than early direct therapy, which require invasive procedures, central line, and so forth. So when you bolus the fluids and you have giving 30 ml per hour, and you, in your examination, that patient is well hydrated, patient is been well resuscitated with the fluids, then here comes the pressors, because you need to increase the perforation of the tissue by limiting the blood pressures, and the pressors comes apart on that. Norepinephrine, which is levophite, is a drug of choice. Vasopressin, epinephrine can be added if the fluids and levophite, which is norepinephrine, is not doing the job. Phenethylamine, which should be used as a salvage therapy. Vasopressins should be administered via central line to decrease the risk of extravasations. So fluids, vasopressors are the 2 components that you want to have a tissue perforation. You measure the lactate. Again, you gotta check the lactate, see if you're clearing the lactate. That will give you the guidelines that you should be done within 6 hours. Again, I prefer more traditional way of checking vitals, physical examinations, and then the lactate, but it's the guidelines. It's helpful to have lactate within 6 hours. So there are several studies done. We have Dr. River from Detroit, who is very big in lactate, has done some studies in 2001, measuring lactate level with early goal-directed therapy, plus measuring the CVP and central venous CO2 monitoring patients, and that he presented, and he showed that early intervention with the early goal therapy has a good outcome as compared to tradition. But there are further studies done in 2014, which is Process, Arise, and Promise. One is it's Australian, I think, studied in Arise is Australian, where they evaluated that traditional the early direct goal therapy does not have benefit in 90 days mortality. So they come up. So the Sepsis Society recommended both instead of just one. So if you do not have physician to put a center line, you follow the traditional as the directed oxygen therapy. So let's go back to the case. 3 bundle was completed. Blood cultures were drawn, labs were drawn, antibiotics administered. 6-hour bundle completed. Started with liver feds. Our mean pressures jump up to 65. Lactate repeated, which is 1.9, which is normal. So we repeated the full PES examinations for fluid resuscitations, including cardiopulmonary examinations, vitals, capillary fills, pressure, pulse, and skin assessment. So patient responded very well. The liver fed was norepinephrine was tapered down, and the mean arterial pressure was greater than 65. Patient had a central line. So she responded very well, and she was transferred from ICU to the floor here. I just put a couple of cases, for 6 cases that I see in this hospital, just to see the history of physical exams and critical thinking is very important in taking care of these kind of patients. I already discussed about the first case, 59-year-old lady with meningitis. There's a lady, that's 45-year-old lady who went to urgent care and for UTI twice, placed on Cipro, placed on Bactrim, and then came admitted with septic shock. Patient has an E. coli, which is resistant to Bactrim and fluoroquinolone. So we need to know about our local resistant patterns on organisms, so that we will not let these people go into a sepsis and septic shock. Nowadays, it's tricky to treat UTIs nowadays because the resistance patterns. What do you do whenever a patient comes in on your clinic with a UTI, or you put Bactrim or Cipro? You need to follow up with the cultures. You need to assess their risk factor, diabetes, and so forth. And then be very cautious about with the care. Have a very close follow-up on these kind of patients. Simply, UTI are not easy to treat nowadays. You have to be on your toes to treat the UTIs. There is a 68-year-old male was admitted with ultrametric status. No complaint offered by the patients. Where family was to say, we don't know what happened. He's just not responding. He's just so he was. When I saw him, he was on BiPAP. His liver enzymes were high, and then all the lab work, which is we did in the ER, was negative except for high liver enzymes. We got a clue. The CAT scan shows liver, and then this require infection control. You gotta control the source of infection. You need to drain the abscess, and if you're doing everything and you're not treating the infections, antibiotic is not always the solution. You have to do intervention to take care of the patient's primary problem. Patient has obstructing stones in kidneys that they come with septic shock. They require to have an intervention along with all the things that we have talked about. This year is the bad year for cellulitis. I have seen so many cellulitis, and they come with the same presentations with most of them. I was fine last night. I was having a chill like I was a wet cat and I have fear, and the next day I saw my legs were red. It's very typical of strep cellulitis. We have 2 patients that were admitted recently in hospital. They were hypotensive. They have their legs, one of the legs, left leg or right, both were erythematous, and they got better, but the leg got worse. But at least they are out of the sepsis. So these kind of patients, how to prevent these kind of things, we need to control. We need to do educations. Obesity. I have seen a lot of people with obesity with this presentation, so they may have to us and tell them to lose some weight. April is the day where I always look for ehrlichiosis. 56-year-old guy was in ICU with sepsis, leukocytosis, and you just see 3 things in your labs. See how that's crucial is lab: leukopenia, thrombocytopenia, and high liver enzyme. You ask one question: have you involved with? Did you have a tick? And he said, yeah, I was doing mushroom hunting. I took 20 ticks out of my, and then you just simply start with IV doxy and then they get better. I mean, that is tells you that history, physical examination, labs are so crucial in taking care of this kind of patients. Another case that we always get challenged over here is C. diff, a 68-year-old lady with bladder surgery. A week ago received antibiotic after having surgery, developed sudden onset of fever, chills and abdominal pain, quite some kind of 40,000. Patient was septic shock, C. diff. We have several cases where we have to go and take the whole colon out. These are the patients, these are people, 6 people. Again, here's the prevention. It says that we need to limit our antibiotics use in our primary care setting to prevent C. diff C. diff incidents. Prevention is the essence of every disease. You can prevent everything, just not to have. Why do you have to wait for them to have septic? 65-year-old people that are in extended care facilities who are very prone to have dehydrations. They have Foley catheter, they have decubitus ulcers. These are the things that we need to provide good care of them so that they will not go to have sepsis. Kids less than 12 that we have to monitor closely. Presence of indwelling catheter IV, we need to proper care for them so that they will not develop any kind of infection with indwelling catheters. Immunocompromise are getting higher and higher in our community. Patients with rheumatoid arthritis on immunosuppressive medications, people with neutropenia. Education plays a good part on those cases. Presence of chronic illnesses, we would like to immunize them with the pneumovax and other needed vaccines. Recent surgery, providing a good education to provide them with good care for their wounds and so forth. Presence of severe burn and wounds are also very, very crucial, and we see a bunch over here. Vaccination is very crucial in people with COPDs and diabetes and so forth. So I will, we just talked all these things already. The patient case that we did, we already have talked about that. So in essence, sepsis prevention is the most important thing in our extended care facilities, along with patients who is high risk for sepsis. Plus, we should know our antibiotics utilizations, along with about our resistance patterns. 50% of staph aureus in our community is MRSA. So it's very essential that we should be on our toes to prevent sepsis rather than treating them. When we diagnose or and assess the patient with sepsis, we have to do a teamwork. These are the guidelines, that is 3-6 hours. I think these are the critical patients, they are the sickest patients that we can do much better. And Leslie will tell you that people do not stay in the ER for 3 hours. They are being transferred in 2 hours. So we can do much better. The more we do fast things and do fast as a teamwork, will prevent mortality and morbidity. How many people live in, stays in the hospital if we do not treat them right? They stay in the hospital for weeks and weeks and go to the nursing homes and so forth. So I will end my talk, and I will ask Leslie to come back and see what her experience is. She have done a tremendous job in the ER. ER physician comes and goes. You have to have a champion of to assess and measure the quality in your facility. And so Leslie did an awesome job. So I will invite her that she can tell us more. Thanks.
Thank you, Dr. Jaffrey. And I just want to kind of build a little bit on what Dr. Jaffrey said about teamwork. I think one of the difficult things about these sepsis patients or septic shock patients is that there's generally going to be a transition of care right in the middle of that patient's initial presentation. So they come to the emergency room, we assess them, we get them started in that resuscitation, and then they're transferred to the ICU right in the middle of that resuscitation a lot of times. So teamwork is truly crucial. Teamwork between the ER and the floor, the ER nurses, the ICU nurses, the ER physicians, the admitting physicians. It's really important to have great communication among that transition of care, so we know what's been done in the ER, what hasn't been done, how that patient responded to resuscitation, just so you have a good idea, no matter where that patient is at in that transition of care, how they're doing in their initial resuscitation. So teamwork cannot be emphasized enough when it comes to sepsis patients. There are so many different things going on with these patients. It involves so many different disciplines to appropriately care for these sepsis patients. So I have to agree with Dr. Jaffrey that teamwork is really, really important. And truly, when everybody comes to the table and is ready to really aggressively resuscitate these patients is when we see, that improved patient outcomes. We wanted to touch just briefly on the CMS core measure. In October of 2015, sepsis resuscitation became a CMS quality measure. So this is something that anybody that is accepting Medicare and Medicaid patients is facing. Just like community-acquired pneumonia used to be a quality measure, DVT prophylaxis is a quality measure, sepsis is very similar to that. It is based off of the 3-hour bundle and the 6-hour bundle that Dr. Jaffrey was talking about. So all of those components that he mentioned are included in this measure. So patients that present in sepsis or septic shock have to have the 3-hour bundle completed. That includes that initial serum lactate. It includes blood cultures being obtained, broad spectrum antibiotics being given. And as Dr. Jaffrey mentioned, the guidelines say within 3 hours, but the true goal is within 1 hour. If you can get an antibiotic administered into that patient within an hour, that's given that patient the best chance to have a reduced mortality. Every hour in delay of antibiotics results in a measurable increase in mortality for those patients. So antibiotics are extremely important in these patients. And also in the 3-hour bundle is that fluid resuscitation for patients that are presenting with hypotension. And again, it's that recommended 30 mils per kilo initial bolus of crystalloid fluid, so either normal saline or lactated ringers. For septic shock patients that are presenting, there's also that 6-hour bundle component that includes vasopressors, and as Dr. Jaffrey said, norepinephrine is the drug of choice for these patients. And you also want to repeat that serum lactate to see if you're having lactate clearance, tell how well you're doing in the resuscitation of that patient. And then it also, the CMS measure also includes the reassessment of the volume status and tissue perfusion. And just as Dr. Jaffrey mentioned, and you'll have in your slides there's those 2 different options. There's the early goal-directed therapy option where you can do that more invasive monitoring, or there's the traditional option where you have to do that focused physical assessment. Just a few a little bit of information about the measure. It depends heavily on provider documentation. One of the things that is important is the time 0. So we want to know what time sepsis presents in these patients, and that's dependent on provider documentation. So documentation of possible infection or possible sepsis or presence of infection kind of starts that clock ticking. So documentation is important, and also that follow-up physical assessment in your septic shock patients can only be documented by your physician assistant, or an advanced practice nurse. So documentation, as always, is very important, especially in our CMS measure. There are a lot of components to this measure. You can see there's a 3-hour and a 6-hour bundle. Within that 6-hour bundle and that focused physical assessment, there are multiple different things that have to be documented, which are there for you in the slides. And you have to meet all of those to say you're compliant with this measure. So it's a composite measure. You have to meet all of those components to say you've met any of those components. So it just adds a little bit of a twist and turn into that measure, and a little bit of a complication, simply because you have to do all of them to say you're compliant. And another kind of twist in the road is that, if you remember, I said the new definitions for sepsis were published in February of 2016, and the sepsis measure for CMS started in October of 2015. So they are based off of those previous definitions, which just adds a little bit of complication and a little bit of, I guess, complication into implementing those new definitions, because the CMS measure is based off of the old definitions, although they are still quite similar. we wanted to share a little bit of our experience here at Union and what we've done to really focus on sepsis as an opportunity for quality improvement in our care. And it started about 3.5 years ago, and what we did first was we really kind of looked at what we were collecting as far as data. So this was before the CMS measure. Now that we have that CMS measure, you should all have good solid data that you can go back to and evaluate. But what we found was that the data points that we were collecting at the time really weren't very useful for driving change. It didn't really line up with the guidelines, so we changed what we were collecting. We really looked at what the guidelines were recommending and said, we want to see if we're meeting those. So we changed what we were collecting, and we used that data to identify opportunities or gaps in the care that we were providing. And I think that's really important with any kind of quality improvement project that you're doing. If you're collecting data, you need to use that to your advantage. Evaluate it, see where there's opportunities for improvement. One of the things that we found was that we had an opportunity in our emergency department. The majority of our patients with sepsis or septic shock were coming into our system in the emergency department. So we found that to be a great opportunity to really focus on the ED and improve the resuscitation that we were giving our patients in the emergency department. We were also able to start pharmacy services in our emergency department about that time, which has really helped as we can dispense antibiotics sooner, we can get that to the nurse, we can help with fluid resuscitation and pressor choice. Engaging our emergency department was really beneficial and has really improved the outcomes of our patients. Another opportunity that we had was for education. Multiple education strategies were employed. We worked on reaching our providers, but also our nursing staff and other disciplines. We did education for our pharmacy as well. And our education focused on that early identification of sepsis and also the initial resuscitation. So we wanted to focus and make sure that we were able to recognize sepsis, just like Dr. Jaffrey was talking about all those different cases. It's important to be able to look at those patients and suspect sepsis and identify it so we can then be aggressive and prompt in our resuscitation of these patients. One of the other things that we found that was really helpful was giving feedback to our providers. So we shared our data with our providers in several different ways. We've done newsletters, we've done flyers, we've done CME lectures just like this one, and we've also developed provider scorecards. So these scorecards are developed for each patient that presents with sepsis or septic shock, and it just tells the provider how well the compliance was with that measure. So it lets the providers know if we are checking blood cultures, if we're checking a lactate, if we are documenting that physical exam like we need to. So I think with any quality improvement, you have to give the feedback back to those involved in that care of that patient so we can all improve together. And the other thing that we really focused on was early recognition. We had a nursing screening tool for sepsis that we used at the time, but we really kind of went back to it, evaluated it, tweaked it, tried to make it easier to use, and tried to make it more meaningful. And our nurses complete that sepsis screen at least once a shift. We also did a lot of education for our nursing staff just to help them identify sepsis, help them to suspect sepsis in their patients. And we also encourage utilization of our rapid response teams. So if a patient had a positive sepsis screen, we really encourage them to call a rapid response, get the ICU team there, get our family medicine residents there to really evaluate that patient and see, do they need an escalation in care? Do they need more investigation into their illness? So rapid response teams are a great opportunity to get additional practitioners there to the bedside to really evaluate that patient. We were working on developing a truly meaningful screening process in our emergency department with the Quick SOFA, the new screening tool that's going to be a lot easier to do because you don't have to have lab values. So we can do that kind of screening on initial triage of patients. However, we're changing EMRs, so we're going to have to see what our new computer system is going to be available to do and what kind of screening is there. But that's definitely an opportunity. So as a sepsis chair, if I were asked to offer advice, one of the things I would say is always do continued follow-up. We continue to measure this compliance, and we still do. We look at the compliance with our 3-hour bundle as well as the 6-hour bundle. We're continuing to share that compliance. We also looked at our mortality. We were really wanting to look at our patient outcomes, because that's truly what this is all about, is making sure that our patients are getting the care that they need so they can have a positive outcome. And what we did was we compared our overall mortality rates for sepsis and septic shock patients. We also looked at the patient's point of origin. So did that patient come through the emergency department, or did they develop sepsis on the floor? Just to kind of compare and contrast and see if there was any difference. And we also looked at our mortality rates when the bundle items were completed versus mortality rates when the bundle items were not completed. And as you would expect, we found about a 10% reduction in mortality when our bundle items were completed. And then we've shared that bundle compliance and our mortality data with our sepsis team, our quality management team here at the hospital, as well as our hospital board. So other advice I would give is, number one is education. We have to continue to educate those that come through our system, not just on what the bundle items are, but why we do those. Why is it important to check an initial lactate and a follow-up lactate? Why is it important to get blood cultures given in 1 hour versus waiting 6 hours to do that? So education is really important. And the other thing I would say is to share the data. That's been really helpful for us. And I think anytime you can share the information with those that are involved in the process and the care of the patient, it's going to help with investment, and it's going to help each of us know how well we're doing. How well is pharmacy doing at dispensing those antibiotics on time so we can get it to the patient? How well is nursing doing at getting those antibiotics administered? How well are our providers doing ordering a lactate or documenting the things they do? I think it's important to share that information. And then the last thing that we've really learned is the early recognition is key. Before we can appropriately treat, we have to identify sepsis and we have to recognize sepsis. So we've really focused on the early recognition of sepsis for these patients. So in a quick summary, sepsis is defined as a life-threatening organ dysfunction caused by dysregulated host response to infection. So looking at our new definitions, that is in the setting of an infection, that is defined as a SOFA score greater than or equal to 2. Septic shock is that subset of patients which have an underlying circulatory and cellular or metabolic abnormalities that are profound enough to increase mortality. And objectively, again, that's defined as persistent hypotension requiring vasopressors to maintain that MAP greater than 65 and a presence of an elevated lactic acid. As Dr. Jaffrey spoke to, sepsis resuscitation has to be prompt and it has to be aggressive, and it must focus on restoring and maintaining tissue perfusion and treating that underlying source of infection. We have to have source control in these patients as well. Sepsis should be detected early, and screening for sepsis with the quick SOFA is just that. It's quick, it's easy, it can be done at the bedside, and does not require lab results. And as Dr. Jaffrey mentioned as well, the best way to treat sepsis is to prevent sepsis. So know who's at risk, know that you have good line care in the acute care setting. If you have patients with central lines, you need to evaluate the need of that central line or that urinary catheter every day. If you don't need it, take it out. That's a risk for infection right there. We want to have appropriate use of antibiotics and all those other prevention strategies that Dr. Jaffrey spoke to. September is Sepsis Awareness Month. So now's the time to get out and talk about sepsis with your peers and get everybody excited to see it, stop it, and survive it. So at this time, Dr. Jaffrey and I would be happy to take any questions that you might have. Yes?
What difference did you see in the point of origin between ER and inpatient?
We didn't see a whole lot of difference in the mortality. The biggest difference that we saw was with compliance with the guidelines. In our emergency department, we've really worked really hard to increase our compliance with the guidelines, and we've done that. And when our patients have developed sepsis on the floor, it's maybe not quite as high of compliance in those patients. There was a small difference in mortality, but nothing real significant. What we have found over the last 4 years, when we've really pushed to try and comply with those guidelines and really hit hard on that 3-hour bundle and making sure we're resuscitating patients, is we've had about a 10% decrease over the last 3 or 4 years in our mortality overall for patients, which is huge. I mean, that's great. That's increasing, our positive outcomes for patients. So the work has been worth it for sure. It's had a positive impact on our patients. Any other questions? Yeah.
Where do you see the fall through? Hospitals, I know the ER has all the resources.
From what most of the time where we have a quote-unquote CMS fallout, or we have issues, it's with that 6-hour bundle. So it's repeating the serum lactate levels, and also documentation of the follow-up physical exam. So there's very specific components to that have to be in there. Has to have vital signs with the values documented, has to have a cardio and pulmonary exam, peripheral pulses, capillary refill, as well as skin color examination and documentation of those results. So there's a lot there that has to be included in that documentation, and that's generally where we see kind of those fallouts, is in the documentation of that focused exam, as well as the repeat lactic acid levels.
We are making it as a sepsis bundle. Why are we calling out on the lactate? It's automatic, it should trigger.
Right, so we're working on that, and at this point that's a system limitation, and that we cannot automatically have that repeat lactic acid order. I can tell you that specifically here at Union, in our coming EMR, we will have that capability, and it will be automatically done based on the result of anything greater than 18 milligrams per deciliter. So at this point, we're working to try and get the system to work for us, and it's been a bit of a challenge, but we're working on it.
My infection is appropriate antibiotics. In this time frame, in this context, we have all the records, outpatients, labs, and so forth. I have seen people I see with IV
Like, well, they kind of finished while ago, so they were quick. I've never seen them talk that quick. Yeah, I am too.
So I think that's what we need to improve about antibiotics.
Yeah, absolutely. I mean, you have to make sure you're using those targeted antibiotics for the source of infection and the patient's history. That's where Dr. Jaffer is talking about the history of that patient is so important. And if they're known to have infections, and we need to know those, we need to know that so we can look and see if we need to change antibiotics. Because, like I said, if you delay appropriate antibiotics for every hour, there's a measurable increase in mortality. So, yeah, absolutely, antibiotics are and appropriate antibiotics are really important. Any other questions? Well, thank you very much for coming. If you have any questions about sepsis, don't hesitate to contact me. I'm in the ER pharmacy, or you can contact me by email as well.